So, welcome to the third series for Harrison based internal medicine 8-minute series. This time, I would like to take you to heat related illness. Before that, I would like to tell you to please share and subscribe and to note whatever points I'm telling in Harrison or in a separate textbook. And if you're going to note it, I'm going to help you out. So, heat related illness is very important, where although significant levels of hypothermia are always tolerated, multi-organ dysfunctions also occur rapidly at these temperatures more than 104.9 or 40.5 degree Celsius. So what temperature you would ask to know? This time around 4 questions was asked on heat based disorders, right? And mechanisms of heat dissipations. Number 1, it is evaporation and radiation, conduction, convection. These are the 4 mechanisms. The wet bulb globe thermometer is commonly used to assess environmental heat load. This can also be asked. And air is an effective insulator. The thermal conductivity of water is 25 times more than that of the air at the same temperature. Direct wordings were asked, mind you, and don't think that whatever I am telling is bakwas or bakchodi. This is what was asked directly. Okay, you might not find it in many recalls because coaching centers staff have not given the exam. Right, sweating rates are 1 to 2 liter per hour in acclimatized individuals during the heat stress. It takes 1 to several weeks for acclimatization to heat. Some of the predisposing factors are always here. It can cause cardiovascular insufficiency. Patients who are having cardiovascular insufficiency will be associated with age extremes, calcium channel blocker, beta blocker, heart failure, dehydration, diuresis, obesity, and poor fitness. Who are having CNS illness are predisposed to cerebellar injury, cerebral hemorrhage, hypothalamic CVA, and psychiatric disorder status epilepticus. Who are having impaired heat loss, predisposing factors antihistaminics, antidepressants, clothing, skin abnormalities, endocrine and immune related illnesses. These excessive heat load, infectious illness, toxicology illness. The thing is that all these will increase the temperature. At the end of the day, only these things you have to know. Okay, which inhibit sweating drugs? CCBs, beta blockers inhibit sweating. So there is increased core body temperature. Prickly heat is miliaria rubia and it's a maculopapular rash, blockage of sweat pores. That's all. It causes pruritus, right? This is what you have to know. Treated with salicylic acid, right? And breathable fabric. Heat syncope was asked again. It is due to most commonly in elderly, right? Due to sudden standing after prolonged exposure to heat or prolonged standing in the heat. Hyperventilation tetany because of heat, which causes hyperventilation, which then causes alkalosis, which then causes hypocalcemia, and which then causes tetany. Cramps was asked again. It is due to a involuntary, painful, spasmodic contraction of the skeletal muscles. Okay. Heat cramps are not associated with significant DID. They are only seen in cases of mild. This is what you have to know. What you have to give them is should avoid the ingestion of undissolved salt tablets, which are gastric irritant and may induce vomiting. So you just have to give them like ORS solutions or 2%, 3% NaCl or 0.1% NaCl solutions. Right? See, this is what they have told. And abdomen is also very rare. These all the things they can ask. Then heat exhaustion also occurs. Right? Core body temperature, it is generally less than 105. Then there is something called as heat stroke, that is more than 40.5. Now no thermoregulatory centers are active. Now we will be having altered mental status. It's very bad, right? It is associated with systemic inflammatory response syndrome. So then these differences of classic heat stroke, exertional street knock will be asked. Classic heat stroke will be having associated older and younger patients, sedentary exercising patients. No sweating is possible. Heavy sweating is there in exertional. There will be CNS injury in cases of classical and hepatic and heart involvement in cases of exertional. Because of that, there can be renal failure. Here also renal failure, coagulopathy, mild, it is severe, marked lactic acidosis, mild elevation of CK, rhabdomyolysis, normal sugar, normal calcium, low glucose, low calcium, high hyperkalemia, rhabdomyolysis, hyponatremia because of severe dehydration. It is due to sporadic cases. Patient is absolutely healthy and young. Because of exercising in heat, he develops exertional heat stroke. Classic, it is due to heat waves, and it is a sedentary. He is just sitting. Okay, this is what. So the cooling strategies were actually asked in the exam. So do you do active cooling or passive? If the patient is unstable, you will have to do a active rewarming. You have to do a rewarming. If he is stable, like passive rewarming occurs. First the body which compensates it. That is called as passive rewarming. So rapid cooling is essential for both the heat strokes. HS is heat stroke. Heat stroke is always bad, remember. Hypoglycemia is also a frequent finding. May require inotropic support after cooling and resuscitations. Because that time the heart rhythm changes will not be seen, because you would have already underwent a cardiac arrest type, and there would be a flat line. So once you give inotropes and you cool him, then you have to start the inotropes for him. You can go for immersion cooling. This is a active, right? Remember, active and passive was asked. Muscular massages, commercial blankets, resuscitation is also very important, right? Aggressive cooling and modest volume reduction, right? This is what you have to know. And coagulopathies you have to manage, tachyarrhythmias after CPR, and after once the temperature is elevated, come down, then you will get to know all these things. No role of antipyretics, right? This is what can be asked. Thank you.